There we go. A very good afternoon to all of you joining us for this session. It's a good afternoon here in Nairobi, Kenya, where I am. I'm Dr. Mercy Korir, the lead group editor for Health and Science at the Standard Group Media, which is one of three Kenya's biggest media houses, where I lead Health and Science, and I'll be your chair for this particular session. So I'd like to welcome all of you to this particular conversation, where we are talking about the impossible decisions, triaging in a pandemic. And we are joined by three doctors who will give us their experiences of what they have seen throughout this particular period, throughout this pandemic. And what this session aims to do is to discuss the challenges of medical triage in the different contexts. And in this case, we have a representation from Asia, from Africa, and from Europe. And then we look at the global challenges that people face, that is in terms of lack of supplies or inadequate supplies and medical equipment such as ventilators or even oxygen in some instances, and what people have been able to do during this particular pandemic. For my colleagues here in Kenya, I know it has been a tough time for some people who have to weigh and, literally decide who gets to live or who gets to wait on. So it's been quite a challenging time. So hopefully with the doctors that we have here, we'll get to hear what their experiences have been. Hopefully not as bad as we have had or we've seen throughout this particular month that we have been facing the pandemic. So we'll get to hear more about their clinical day-to-day challenges, as well as the ethical implications of triaging decisions. And I'll introduce my panelists shortly, but I'd like to welcome all of you to interact with us. To your right on the side is a chat option where you can pose your questions to any of my panelists as we go along, and I'll get to pose the questions to them. We also encourage you to comment on Twitter using the hashtag HCBerlin, H for hotel, C for Charlie, so HCBerlin. Comment and gets to interact with us throughout this conversation on Twitter using that particular hashtag. Now we have also accessibility features, that is the international sign language, to be found in the session area, and then we have a live captioning link on the reception area. But if you have any challenges throughout this particular session, there is a help desk in the session area where our people on the backstage will be able to assist you. So welcome all of you to this conversation. So I would like to introduce my panelists for this session. First and foremost, from Indonesia is Dr. Ramawati Hussein, who is the Vice Chairperson of Muhammadiyah Disaster Management Center. Welcome, Dr. Hussein. In Kenya, we say Karibu Sana. We have Dr. James Smith from the United Kingdom. He's an emergency physician with the NHS. Welcome, Dr. Smith. And last but not least is my colleague right here in Nairobi, that is Dr. Frederick Oluga, who is the Director of Health Services at the Executive Office of the President. This is managing our health services at the Nairobi Metropolitan Services. So welcome all of you, and feel free. We'd like to hear more about your experiences during this pandemic, and particularly looking at those times when you had to make those impossible decisions. And I'll start with Dr. Smith. What has been your experience triaging during this pandemic?
Thank you, Dr. Mercy, and thank you all for the opportunity to speak today. It's a real pleasure to be on this panel. By way of a little bit more background, I work as a physician in the UK. I work in an inner city hospital in London. I also separately have an MSF hat, which has allowed me to sort of engage with the global perspective. My experience of the pandemic, and by way of a caveat, or by way of a bit of extra detail, I only really worked sort of 15, 20 shifts during the height of the pandemic. So I've really gained a lot from speaking to colleagues who were in the hospital day in, day out. I was not one of those people, but I certainly tried to gain as much as I can from colleagues in the run up to this particular discussion. So, impossible decisions, and particularly the question of triage. What has been most striking to me is the way in which we've engaged so substantively with the question of triage and the allocation of scarce resources during COVID. There have been a flurry of opinion pieces, personal testimonies, more academic, theoretical reflection. But triage, in the simplest sense, is part of everyday medical practice. We do it all the time. It's part of an efficient healthcare system that we triage and we establish who needs to be seen first and who can wait a little while longer. The issue here is the added complexity of allocating scarce resources. And as you say, Dr. Mercy, the way that manifested for certainly colleagues in the UK healthcare system was this difficult decision around who should be allocated a seat in the intensive care department, or a bed, sorry, in the intensive care department, and have access to the full range of clinical treatments, including artificial ventilation if required. And those were incredibly difficult decisions. This was a process that is, even at the best of times, incredibly difficult to navigate and negotiate. And it is indeed a process of negotiation with colleagues, with family members of the patient in question, with the patient themselves. But it's also a process of resistance. And certainly my experience as a physician is that even knowing that systems and processes exist for the ultimate benefit of a population, it can be very difficult not to do as much as you possibly can for an individual person. And I think at the early stages of the pandemic, the way that manifested most tangibly was that wherever possible, we were allocating people places in intensive care units. So very quickly, the departments were filling up. Very quickly, we had to roll out additional capacity. You may be familiar with the big Nightingale hospitals. So these images of sort of rows and rows of specialist units, people being asked to come out of retirement to staff these facilities. So I think for me, that's really been the experience of triage, but also triage in the context of scarcity. This kind of constant negotiation and constant kind of resistance between sort of healthcare practitioners, patients, their families, and indeed the wider political environment in which this whole process is negotiated. I'll leave it there for now.
We'll definitely revisit that, especially the conversation of resource allocation, where you think you have enough resources, but then you get into a negotiation. But let me come to Africa. The initial prediction was that, Africa will be hard hit, knowing that our health systems are a bit weaker than we would want them to be. And we thought, COVID-19 would really bring us down in Africa, and we may not be able to survive or weather the storm that comes with it. But Dr. Oluga, you've seen that Africa has really not suffered as much as it had been predicted earlier. So have you been in a position where you have had to make difficult decisions such that, if the patients who are coming are really sick and they need to compete with other illnesses that still need the same kind of attention in the facilities?
Thank you, Mercy, and thank you for the other panelists, Dr. Hussein, Dr. Smith, and to all the people joining us in this very interesting conversation. So first and foremost, I think in terms of absolute numbers, perhaps Africa is not as affected as other countries. But I think in terms of impact, we are equally affected in more areas than just the medical sector. So from where I sit and having been the task force chair for COVID-19 in the whole of Nairobi, I think I can summarize it in three different ways. One is that as far as triage was concerned, we were still having a big challenge, especially in the city, as you know, and perhaps for the benefit of the viewers. So we generally are in charge of facilities that are public sector facilities and that are located within the city of Nairobi. And out of all the facilities that we have, around 106 health centers, dispensaries, and hospitals, 4 of them are managed by the national government, and then 102 are managed by the county, or now what is directly in our custody. And so if you're talking about people who really needed care and people who got really sick and wanted hospital care, there was quite a huge shortage of critical care units in Nairobi. Because as far as the national government is concerned, there are only 2 hospitals that have ICU care. That's the Kenyatta National Hospital and the Kenyatta University Teaching and Referral Hospital. And in total, those are just 57 beds. One has 26, another one has 31. So you can see from where we are starting in terms of that huge shortage. Out of the 102 facilities that are directly under our care and my management, there was not a single facility with any high dependency unit or intensive care unit. So this is the situation that we are dealing with, and you know, COVID-19 is a respiratory illness, affects a lot of people, and most times they need supplemental oxygen, sometimes they need high dependency care, sometimes they need critical care. So this is the disadvantage that we were starting with, and we were starting from scratch. And so this first aspect of in terms of impact preparedness, so we were actually not prepared. And then now moving on to what steps did we do and how did we deal with it, and this is where the question of triage comes in, is we had to negotiate with private hospitals, because Nairobi has 406 private facilities. Out of these 406 private facilities, 11 of them are mid-level and big hospitals. And out of these 11 with mid-level and big hospitals, 7 of them have infrastructure to support patients who are in critical condition. And at the beginning of the pandemic in March and in April, only 2 facilities, that is the Nairobi Hospital and the Aga Khan, had set aside beds that could be used for patients who really needed care. And of course, these were also quite costly. It's not available to the ordinary Mwananchi. You have to go out of pocket. And even then, there were only few. For example, at the beginning, Aga Khan only set out 3 beds for COVID, and then the Nairobi Hospital, just a few of their beds in the ICU. So one of the things that we quickly did was to go hospital by hospital and try to negotiate with them, first to make more beds available in their critical care units. And then second, in terms of, and this was a big negotiation that we did not win, in terms of cost and how the general public would actually access these facilities. And so when we went around, we did this mapping together with the Ministry of Health. And actually we sat with hospital management, and I almost want to use the word we forced them, I think from a government perspective, to allocate more of their ICU, HDU beds to patients who are suffering from COVID. Remember that the COVID-19 was a very expensive disease, especially from a private sector perspective, because apart from the normal resources that are required to take care of an ICU patient, there were additional costs. You know, this donning off, donning on, PPEs are very expensive, oxygen is costly, and then now you have to increase the number of staff that are usually working in shifts. So from the private hospitals, was quite a difficult decision, but that is all that we had because we needed something quick. Then, of course, later is to now discuss how we use that in terms of strengthening the healthcare system. And of course, we allocated a bit of resources also to try and now improve the infrastructure. And for our facilities, the 102 that did not have facilities, now we are setting up 2 ICUs, 2 beds are already ready. And another facility is now setting up a 5-bed ICU. Just so that, because we are still within the pandemic, in fact, there are some discussions that Kenya may be experiencing the second wave. But beyond this also are challenges that were facing the health workers themselves. First, of course, the anxiety of interacting with COVID-19 patients, but secondly, also the reality that most of them are the affected and they're the most at risk. And I think all this, for us, it played in reality. It was not just about anxiety, because I remember we had a number of health workers that were infected. At the beginning of the pandemic, in April, May, here in Kenya, we had around 14 patients or 14 healthcare workers, let me call them staff, who are all affected. And this is the first time, we are discussing the issues of triage. And believe me not, we did not have anywhere to take them because these are health workers. We had very few isolations at that particular time. We had the challenges with the treatment centers, and now you have your own staff who are sick. And this is the time we started discussing where do we isolate healthcare workers. And it's a very difficult decision because for some of them with comorbidities, one of them got really sick. And we have to go through the whole process again of just not negotiating for the general public, but we had to go to a private facility and actually negotiate with Nairobi Hospital just to admit one of our staff. So these are really challenges that we were facing here in Nairobi, we are still facing.
Mainly infrastructural challenges that literally got the health system and its users and not ready to handle the pandemic. So we'll come back to that, Dr. Luga. Let's hear from Dr. Hussein from Indonesia, whether the challenges were the same like what we were facing in Africa or the ones that are in the UK. Dr. Hussein, what has been your experience in triaging?
Thank you. As I listen from the previous speaker, and thank you again for inviting me. I have to tell that I'm not from the clinical physician and I'm not in the emergency physician, but I'm an emergency manager for the disaster management in Muhammadiyah. To give the background, Muhammadiyah is non-profit organization in Indonesia. It was founded in 1912, and it has around more than 437 health facilities throughout Indonesia. It's contribute to 10% of health system in Indonesia. So what we do is complement to government, because in the case of Indonesia, in the very beginning, the cases are very small number and then increasing very quickly because of the there is no lockdown, and then there is no clear policy in the very beginning. So what we do is preparing our hospitals. So we Muhammadiyah preparing 82 hospitals that have ICU and has the equipment to provide the care system for confirming the confirmed patient. So it's really interesting when people do not want to go to the public hospital or the state hospital, because they are, when in flux of the confirmed positive, they are having a fear to be contacted. Then they go to the non-public hospital, non-profit organization, and then they when everyone right now is increasing, because the cases in Indonesia right now is 406,000 confirmed cases, and with the 13,000 deaths, the 2 days is already 406,000, and then 13,700 deaths. And we still have many suspect that around in many hospitals throughout Indonesia. The problem in Indonesia is archipelago. So the country is stretched like from London to Moscow. So it's really far. It's like the US, the size, but 80% are water. And only in main island have the very good health facilities. That's why the government try to do more on health promotion to mitigate instead of like curing. So what we do here, like my organization also do huge health promotion to mitigate the people. To mitigate transmission and protect civilian for the infection. This is very important because to transport to the main island to the city that have a good health system, it will be costly and takes time. So the tries that we do is pre-hospital activity. Mostly what we did is like to provide self-isolation center for asymptomatic and also mild COVID-19, asymptomatic, and the quarantine center is dedicated for those who tested positive but who do not have or have no symptom. So we try to separate hospital and the self-isolation center for asymptomatic death. So that's in every district. The government and also like my organization, Muhammadiyah, providing the self-isolation center. So in this case, the facilities is also supported by the neighboring hospital or the nearby hospital to check the development of the self-isolation center. So this to avoid the influx to the hospital. So the self-isolation center right now in every district help to triage the things. And we always, the government and also the Muhammadiyah hospital throughout Indonesia only prioritize the ICU or the hospital for the severe patient or with patient with the comorbid or have the pre-existing condition. So what we do try to differentiate between hospital and self-isolation center that's supported by the hospital. And also we work with the partner to increase the facilities like Muhammadiyah. I myself responsible for working for partnership. We partner with the USAID, the Australian government, the Singaporean government as well. Since Muhammadiyah hospital is not like state hospital, we are lack of ventilators and oxygenator and other equipment. So what we do is also working in partner with other donors to get additional equipment, because right now there are many, because since the surge of patient to the state hospital, now people moving to our hospital, to the non-profit hospital. So we are not supported by government. So what we do is we work with the partner to provide better equipment and also to protect our doctors and other physicians and also nurses, because so far from 82 hospitals that serve the patient, we already have almost 125 medical staff that infected during the hospital because of the lack of the PPE. So it's very important to protect the health staff or the health worker, because with the lack of that, it is very very dangerous in long term, because we are lack of people who are taken care of. So what we do right now is enforcing for health promotion. And then also the government of Indonesia strengthening the primary care for trias, because many people in the remote area or in the island, they're not going to the hospital, but to the primary clinics. So the primary clinic become very important to have to be protected and to have the ability to do trials, whether they are symptomatic or asymptomatic or with very mild. And also we also do train the community, because there are, like Dr. Smith mentioned, there are resistance and stigmatization is among the community, because they feel that if you are once infected, it easily goes straight. Like one of our nurse was not welcome home because they were the community afraid that she will infect all the whole community. So it's not easy for the health worker to go home, yeah, because of the stigmatization. That's the first. And then the second, for the patient itself, one of the example that we have in our hospital, we have one case of the road accident, the traffic accident. And then when we diagnosis, he got pneumonia. And then when we do X-ray and also check with the PCR, he was finally got the diagnosis with the COVID-19, but the family didn't accept it because he just got the accident. Why you put it in the COVID confirmed patient? So it's always hard to convince the family for having a resistance that this is the COVID is some very contagious and bring the death, and then they feel that they are stigmatized, not being accepted. So I will stop from the introduction what we do. Thank you.
Okay, thank you, Dr. Hussein, for that elaborate explanation of what you're doing at Muhammadiyah. And from listening to you, Dr. Luga and Dr. Smith, is that it's a continuum of points of triage from the pre-hospital care, where even the patients themselves are deciding whether to go or not, from the primary health care perspective, from at the hospital, and then at the hospital you have the patients, you have a healthcare worker. So it looks like it's a continuum. And now my next question to the three of you, and we'll start with Dr. Smith. What ethical questions or challenges come up with all of these things, because we know of the implications of if you get triage wrong or if you get triage right. So looking that we're in a pandemic, there's need for healthcare services, good healthcare services. What ethical questions come up here?
Thank you, Dr. Kalia, for the question. I think in the most what we're talking about here in the most fundamental sense is that kind of classic ethical dilemma between trying to provide a certain standard of care for the majority of people versus providing the greatest possible care for an individual patient. And that kind of tension between individual medical ethics and wider public health ethics is a really kind of fraught area to exist within. And these are very difficult conversations, particularly for healthcare providers who have trained to provide the highest quality of care to their individual patients. So you're really, you're being forced to reflect continuously that you're not only treating the patient in front of you, but you're also trying to consider in real time how you balance the desire to sort of invest resources intensively in one unwell patient, and how that might detract from your ability to care for others. The real challenge for COVID, though, is that very unwell patients, that sort of 10-15% of patients with coronavirus that require or potentially require hospitalization. We're talking about very intensive levels of treatment, or a very high ceiling of care. You know, if your parameters are that you will offer an individual patient high flow oxygen, the next step beyond that is assisted ventilation, which requires a high dependency unit or an intensive care unit and specialist staff and so on. So there aren't many rungs on the ladder. Once you've decided that you're going to commit those resources to a particular patient, you've made that commitment. And the next difficult decision that you might have to make is, depending on how that patient responds, withdrawal of treatment. But I just have one additional point, Dr. Korir, to your question of kind of this spectrum of triage, both in the pre-hospital setting and in hospital as well. As an emergency physician, and indeed for any hospital-based healthcare provider, I think it's incredibly important that we do acknowledge that these stages of triage have preceded the presentation of an individual to an emergency department. We are seeing a subset of the population, and there are many people out in the community, who either, as Dr. Hussain mentions, are fearful to present, or who may, for other reasons, already be concerned about healthcare seeking. So undocumented migrants, for example, in the UK, who have historically had, and in the present day, have a very difficult experience accessing healthcare for fear that they might be reported to the immigration authorities. There are certain groups who are much less likely to present. And what you see, particularly during the pandemic, is this real galvanization of healthcare workers around a more overtly political expression of healthcare provision and of public health. People are much more aware of those access impediments and the fact that indeed these, if you like, invisible stages of triage precede the presentation of anyone to hospital.
Dr. Smith, on that vein, let me pose this question from Edward Chu to yourself. Do you worry that the use of triage to refer to resource allocation contributes to confusion regarding the usual activity of triaging patients in emergency departments?
In short, yes. I think we need to distinguish between a couple of different issues here. As I mentioned, triage is an everyday process. This is something that we do all of the time to ensure that a department or a facility works in the most efficient way possible. I think what we're getting at here is indeed the triage process within the context of scarce resources. So really we're talking, or at least I'm talking about the allocation of scarce resources and the difficult decisions that are related to that process.
Okay. Thank you very much for your answers and your comments on that. So, Dr. Oluga, from your perspective, almost every other day, because of the resource limitations, you find yourselves, and I have been there myself, at a point where, as Dr. Smith says, triage is a matter of, it's an everyday thing. What ethical issues or questions come up from the African context where you are at?
Yeah, I think in nearly all contexts, triage is because of limitation of resources. I think whether in the West or in Africa, but I think in Africa we experience it more because even what I would call the acceptable standard, is not there. As I was mentioning to you before, every single day in all these facilities, we see patients who need critical care. Even before COVID, we did. And I think, as you mentioned it, you have been there before. But even the access to that care is not there. Even to make the decision of even transferring them is not there. Sometimes even the provider who is capable of making a decision is not there. So I think we've this is the reality that we go through in these resource limited settings, but it is also the reality that was exposed by COVID-19. And as Smith said, there is the general talk about health now more because of the issue of the security that has come, the global health security that comes with a pandemic such as COVID. And I think we saw a bit of this also in Africa during the Ebola, where health is now looked into not just as a human dignity, human right issue, but more globally as a security and an economic issue. And I think from what you said, for us, the biggest challenges that we've had in terms of triage, and I saw one of the participants asked a question, is even getting the staff to participate, because initially it was very difficult to recruit staff to participate in either quarantine, isolation facilities, and even to do case management. And it's a very difficult effort. And that's where, when we talk about triage, these are the same people who are going to be making the decisions. But from our perspective, it was also a bit challenging to sort of convince some set of nurses and doctors that for you're going to be managing COVID-19 facilities, and for you're not going to be managing COVID-19 facilities, because also we had to leave some level of care for the other hospital services. And I think there was a very interesting experience at some point, because the initial trainings that we did for health workers, the ones we trained, we spent quite a lot of time, WHO supported training of nearly 2 weeks for people who are going to be in the case management. All of them actually declined to work in the training because they were trained way before the first case was identified here in Kenya. And then once the first case came in, and this is true for Nairobi, the initial people who were trained, now and then you find one is on leave, one tells you they have a comorbidity, another one, and then we later realized that it was an issue of the fear of actually doing the actual work. So we had to actually go around again and start looking for staff who are more willing, but also who are specifically in those, if they are physicians, and we had to make very strong case management teams. And one of the things also that came very clearly during the case management training was actually for us, it's a pre-hospital where we choose symptomatic, non-symptomatic people. Who are we giving what level of care? Because we don't even have that level of care anyway. At the highest level for us in our facilities, what we had was supplemental oxygen and CPAP. We did not have ventilators. We're just setting them up now. And then at the national level, of course, we could refer for ICU care. And so it takes a very delicate decision to even select the staff who are going to make these decisions about triage. And so when we talk about resource, it even starts with the human resource, about the decisions about triage. And that's how interesting this pandemic has been teaching us lessons here in Nairobi.
So resource, not just the equipment and facilities, but also up to the human resource. To Dr. Hussein, and I don't think I could have asked this question any better. So Maria says it's interesting to think about pre-triage before emergency room triaging from a form of community triaging through health promotion and decentralization process. As brought up regarding stigma, can you expand a bit more on the ethics of duty of care and to protect staff and patients? Dr. Hussein?
Thank you. Yeah, it's not easy question, and also I try to elaborate the issue, the conflict that day to day that faced by the physician and also the community because of the stigmatization. So what we do as because my organization is a Muslim organization, religious organization, so we use the leaders to influence the people that the COVID is something that you need to prepare, not to avoid, because you cannot avoid wherever you go. If it's infected, then it's need to do the to prepare, to prevent for infected. So what we do from the community perspective, we like work like 24/7 to do, even using the mobile speaker, yeah, to enforce people to clean, to promote using face masks and everything to was most of the time, and then also to avoid gathering in the mosque, because the 80% of Indonesia are Muslim, they are going to the mosque. Even hard for us as a Muslim organization to prohibit people to go to the mosque or to the church, yeah. So it's not easy. So what we do from the community, to provide the support to the health worker as well, so that the diseases or the coronavirus is not need to be stigmatized, but we need to support them by providing some support. So what some community right now, even up to now, they if one household infected by coronavirus, then other community will help them to provide food, for example, to provide day-to-day basic need. So what to avoid them going to the hospital, to keep them to have the better immune. So the community support system will be established in the neighborhood level, and then from the neighborhood level, if things happen, they go to the primary care. From the primary care, if it's getting worse, then go to the hospital. So we try to set up based on the community resource first, for keeping the community to be healthy enough not to be infected, or if infected, then they can recover soon in 14 days. So the self-quarantine is 14 days, and during the 14 days, they are supported by the neighborhood. So the neighborhood support to avoid people going to primary care. If reducing the primary care, it also will reduce the hospital. So that's what we in my organization work is try to focus on that. And if it's come to worse, we try to because everyone actually in population demands some intervention to keep them from harm and save their life, not only from current coronavirus, from pre-existing conditions. So what we do is we also differentiate or build a different ward for coronavirus and for the other. So or one hospital dedicated only for coronavirus, the other hospital are dedicated for non-coronavirus cases. So this trials has also been done in our health system to provide the full care, because it's not easy to pick which one first, the people with the heart attack first or the coronavirus. So what we do then, the government and also my organization, because we also do have 100 hospital, try to differentiate the hospital, or to try to make a difference between the hospital that's solely for coronavirus and the other is for the regular consultation or the regular outpatient hospital. And
so picking just from there, Dr. Hussein, sorry to barge in, is an interesting question here that I would like all of you to answer. We can start with you, Dr. Hussein, about stigmatization and the ethical dilemmas around it. And Sabrina is asking all of you if you noticed any person who was denied access to COVID-19 vital medical care, as well as life-saving equipment or medicine, based on their age or disability. And she quotes a letter written by the International Disability Alliance to the WHO to take immediate action condemning any form of disability-based or age-based prioritization in providing COVID-19 medical care. Because we only have about 15 minutes, I'll just answer this briefly. Did you notice at any point anyone being denied care because based on their age or disability in Indonesia? Were there any cases of that?
As long as I know, no.
No. Okay.
No.
All right.
The problem is from the patient. The patient they do not want to be identified himself or herself to be a positive COVID. So they don't want to go to be treated as a positive. So that's a big challenge for us.
Okay, so not based on disability or age. Dr. Smith, what about your experience from the UK? Because Sabrina says in some EU countries, particularly, this ethical dilemma arose.
No, I think it's a really important question, and I'm aware of the letter that's mentioned here. So in short, not in my personal experience, though this is something that has been discussed a great deal within the wider medical community. And I have no doubt that indeed this has happened. If I can speak to the question of age, even just speaking to my older parents, there's a sense of sort of frustration or concern for having been grouped with, those over the age of 60 or those over the age of 70, and all of a sudden you're kind of categorized as elderly and subject to all sorts of risk analyses based on that age sort of stratification. And there is a concern, I think, among a number of people, and this has been well documented already in the mainstream media, that, if they were to present to a healthcare facility, that they feel that, their age would be against them. So I think it's a very valid concern that, an individual should be, their access to more specialized forms of treatment should be judged based on the clinical need and the likelihood of a positive outcome. And indeed, these additional kind of characteristics shouldn't really be part of the equation. But unfortunately, as you see from the fact that a number of patient advocacy and other institutions that have had to sort of speak up about this, it has been a widespread concern, and I think it has indeed manifested in some contexts, particularly at the height of the first peak, where resource allocation was a particular problem.
All right, thank you. Dr. Luga, any age-based or disability-based prioritization, or what has the prioritization been based on in Kenya?
So for I haven't seen any form of discrimination. Of course, I've had concerns from either patients or their relatives who are calling. I think like this morning, someone called me because I think their parent is 72 and has COVID and has comorbidities, and of course they were concerned whether they will have access to isolation, and even if they needed high dependency of critical care. And so far we've not had any reports of any age-based discrimination. But I think it is important to anecdotally, there may be biases at the level of the provider, and where the provider, either the physician or the person giving care, where sometimes we tend to stigmatize based on the fact that, this is COVID-19, but you have a lot more comorbidities. And I think for me, what I have observed or perhaps had generally is that there's that tendency to sort of say that because this person is either aged or has a lot more comorbidities, it's sort of, they are not really prioritized in the treatment or in the intensive care. But I think this is more of maybe a bias, as Smith said, discussions within the medical community. So I'm a member of the Kenya Association of Physicians, and this is some of the things that we also discuss because, recently there was one of the continuous medical education sessions where we were actually having this discussion about people with the advanced stages of, for example, a CA or other complications of diabetes or hypertension or heart disease, and then they come to the facility with COVID, and the whole area of management. And again, it comes back to the prioritization. So I think it is a very valid question. And I think at the individual physician level, as Dr. Smith says, I think it occurs, but it perhaps not in Kenya widely reported to an extent that it is a concern, or that you can say that there is a policy direction around it. I wanted to ask Hussein just one question about how they do the neighborhood support. You mentioned pre-hospital care where people go to isolation, and then you mentioned some interesting idea about neighborhood support. Maybe you could clarify.
Okay, if I may go directly to the neighborhood support.
Dr. Lugas,
okay,
taken over the chair's job, but it's okay, Dr. Hussein, go ahead.
Okay, thank you. The neighborhood support mean that the neighborhood will support the basic supplies like food, drinks, ready meals, for daily meals, because if they are allowed to go out, meaning that there are the potential for infected. So the confirmed patient in one neighborhood, for example, and then the head of the neighborhood will talk to the community. They will take turn in providing food for the family that infected. So there are different terms in every island. They have the different term for that, but they try to build that. So the one household to have like 4 person in the family, and then they will get enough food, enough drink, enough daily needs that's supported by the neighborhood. So that's if they are isolated at home. But if they are isolated in isolation center, they are supported by the government or the organization. So it's different type, because some they still want to be at home with their family, but some are willing to go to isolation center where they got the support from government with the more structured daily activities, such as like having exercise, workout, and then every day is also physician come to the isolation center to check if there are going fever or something that getting worse from the COVID. So they try to also separate it from the more mild COVID cases. So that's the 2 different way of like isolation center that usually do.
Okay, thank you. Thank you, Dr. Hussein. Thanks. I think Dr. Oluga has been answered. So Victoria is saying that it's interesting to see how COVID-19 reveals social problems on both rich and poor countries, as has been represented by the experts here, the panelists, problems that have been there all along in history. And Susan Myra is talking about balancing between COVID and other non-COVID patients, such as acute on chronic emergencies and other chronic non-communicable diseases, such as diabetes and cancer. And we know that, from the look of things, COVID is here to stick with us for a while. So this is now my last question to all of you, just looking at what we have seen in retrospect and now moving ahead. What are your recommendations so that there is a balance between offering care to COVID and, as Susan Myra aptly puts, there are other diseases, that also needs triage and also need the same resources. What would be your recommendations in as brief as possible, starting with Dr. Smith?
It's a really important question, and certainly at the height of the first peak, one of the most dramatic changes that we saw in emergency departments across the country was quite a dramatic decline in the number of people presenting with non-COVID pathologies. And that's, of course, not to say that people aren't having heart attacks or strokes in the community, or indeed that their diabetes and so on is not deteriorating in the absence of regular community follow-up. So it's incredibly important in any situation like this. And indeed, COVID is not the first time that we've had to grapple with this question. But really, any health system that reorientates itself to facilitate management of a single pathology is inevitably going to undermine gains that have been made in the care of other diseases. And we've seen this with Ebola. We've seen this with disease-specific responses to complex global health problems. And we see it again now with COVID. Now, that early reprioritization during the first peak is perhaps unsurprising, because there was such an urgency to get on top of the dramatic increase in cases. But what we absolutely need to see now is integrated service provision that does not neglect access to other forms of care. And perhaps one small example, if I may, Dr. Korir, is that during the height of the first peak, you can't just speak, and Edward mentioned this in one of his questions, you can't just talk about number of ventilators. Ventilators don't function as autonomous machines. You need an entire staff, you need a fully functioning system in which to use those ventilators. So we were pulling colleagues from community care, community sexual and reproductive health services, for example. Now, it's perhaps too soon to tell what the knock-on impact of that shift has been on morbidity and mortality for non-COVID related problems. But I would be very surprised if we don't see some really quite stark statistics in the months ahead. And I guess one final point in terms of how do we prevent, or indeed how do we move forward from here, and this is perhaps a nod to Victoria's question, we cannot again invest in issue or disease specific health system strengthening. What COVID has exposed is the under-resourcing of healthcare systems worldwide, the reorientation of financing towards non-essential social public services. And I think we really need to use this opportunity to reorientate our domestic policy making towards those essential services, healthcare, education, and others.
Mm-hmm. Thank you, Dr. Smith. I'll go to Dr. Hussein and give you an opportunity also to just answer this question as you give your final remarks and recommendations. And this question from Maria, from the care provider perspective, seeing that you're dealing a lot with pre-hospital triage and community care. So from the care provider perspective, can you reflect more on the moral distress of ethical triaging at that particular point as you give your final comments and recommendations?
Okay, it is important question, and also I want to echoing what Dr. Smith mentioned, that we have to reorientation again the what we do in health system, especially in a developing country where resources are very limited, and in the case of Indonesia, because of geographically, is also it's a problem. It's difficult with 17,000 islands. Only the privileged people that can go to the main island and then get the good access to the health system. So it's very important to rebuild the good health system in the future. And the primary care for us is the most important. So the primary care or pre-hospital system has to be strengthened to avoid the influx of the problem. And also what I think is for the most important is also the health promotion. The educational and awareness is also part of the problem, because there are still many community in Indonesia think that COVID is still hoax or something, that it's a disease from God or whatever, not scientifically responded. So it's very important to get more and more education, and then public health education, and then primary care strengthened especially in remote area, and also the increasing the capacity of the care provider. So it's very important, not only understanding the new cases, the pandemic. Like in Indonesia, we've been dealing with still the tuberculosis is still everywhere. Even the death because of the tuberculosis is still higher than COVID. But right now, everyone thinking only COVID, and then not thinking about other epidemic like tuberculosis, dengue, malaria. It's also still occurs in Indonesia. So we still have to work with the public health system to improve the public health system. And I think in the future, the donor should also balance this, not only look at the more crisis on pandemic that just arrives, but it's also the existing epidemic that still happen in many countries. Like in Indonesia, we still has huge problem with the dengue, malaria, and also tuberculosis that we right now dealing with more. I think.
All right. Thank you, Dr. Hussein. Dr. Luganda, I will pose this last question to you from Rod Mena as you give your closing remarks. So how do you balance the process of triage and targeting? Some donors or governments will promote aid to be delivered to a particular group of people, but after triaging, it can be seen that others might need aid more or more urgently. That I think what it means is that after triage, you realize that, the targeted group maybe do not need that aid more. So I don't know what you have to comment on that as you give us your recommendations or way forward concerning making this impossible, difficult decisions in a pandemic.
Yeah, I think the whole answer to the triage difficulties, and Dr. Smith already led us in sort of talking about it, that we cannot do disease-specific policies, disease-specific funding, disease-specific prioritizations. I think there has to be some level of a whole approach to the system that takes care of even what you have talked about, the target groups, so that people don't feel like, for us who have, for example, lupus, we have been neglected. And those other people with, the suffering this condition. And I think this is, at the global level, there has been this problem where if there is an increasing wave, for example, for cancer or a particular cancer, then there's a lot of support towards it. And now it's COVID, then there's a lot of support towards COVID. And I think it's also at the policy level, at the national level, at the country level, and also at the sub-country level. So, for example, where people like us work, we have to even take advantage of pandemics such as COVID to sort of, to sort of spread the resources to cover all groups. And I think, for example, if you're going to build an ICU the way we are doing, you may use, yes, COVID funds, but an ICU is required every single day by people who are getting diabetic ketoacidosis, by many other people, by people in road traffic accidents. So I think this is really the way to balance it in my thinking, and then because on every day my work actually is policy, so I am also the one in charge of policy and quality assurance, and also to look at how do you take advantage, for example, of resources and the systems that have been built for HIV or for TB. And yesterday I was asking our communication, not communicable diseases department, and I was asking them, the systems that we have built for a long time, for example, to deal with diseases such as TB, because we have very good system. We have, directed observation therapies. We have systems of identification. We have outreaches. Can we sort of try and now use some of these systems to go to respiratory diseases such as COVID? Yes, of course, it's still a pandemic. It's still notifiable. But we can also leverage on what was built before to sort of also balance the use of resources so that we are not creating a completely different and, in my submission, narrow system for COVID that also leaves the other diseases. And I think for us here, we tried, even in May, we tried and opened clinics when it was not yet safe to do so, but we tried just so that we are not giving undue advantage or disadvantage to other diseases. But yes, that's a very valid concern. I think it is the dilemma of many policymakers, usually, because it is directed more by funding. So, for example, if World Bank says that they have money more for COVID, especially for resource-limited settings such as ours, where we depend sometimes on grants, on donors, and policies may not necessarily be coming from us, I think it's then upon the policymaker to see how to distribute the prioritization of the resource to benefit every single part of healthcare.
Okay. All right. Thank you, Dr. Luga, Dr. Smith, and Dr. Hussein. I think my closing, my take home from listening to all of you and your experiences in the 3 different parts of the world is that strong health systems are important, and for us to look at not at disease-specific systems, but systems that will cater to everything all the time, because it's, if you need an ICU, as Dr. Oluga, you've said, for COVID, you may also need it for something else. So I think the running commentary that I can get from all of you is that that strong health systems, or looking at it holistically from a health system point of view, is important to be able to balance these difficult decisions of triaging. And also that resources are not just equipment and, the ventilators that we've been talking about throughout this COVID pandemic, but also the human resource to operate them, because as Dr. Smith says, you'll have a ventilator, yes, but who operates it? And last but not least is to deal with the communities. I think that has come out very strongly from Dr. Hussein, from the community point of view, from primary healthcare, and having communities support where they can. So I think that would be the first point. And so it's a whole continuum from community to the most critical care, where all of these decisions come in. And I think that is what I have picked from this very insightful panel conversation. I hope all the audiences, everyone that we've had here, has picked the same or anything else. We'll be happy to hear from all of you. Remember, you can still continue engaging with us. To the left of your screen, or to the left bar of the screen, are opportunities for networking and the expo on that space, so we can continue having these conversations there. So please, after this, you can still chat and have networking sessions and the expo sessions on that side. On this panel this afternoon is Dr. Ramawati Hussein, who's the Vice Chair of Muhammadiyah Disaster Management Center in Indonesia, Dr. James Smith, who's an emergency physician at the NHS in UK, and Dr. Frederick Oluga, who's the Director Health Services at the Executive Office of the President for Nairobi Metropolitan Services here in Nairobi, Kenya. I've been your chair for this session session. My name is Dr. Masi Korir. I'm a health and science editor at the Standard Media Group based here in Nairobi, Kenya. And so thank you very much for your engagement, for continuing to talk to us. So we hope to catch you on the left of the bar and continue the rest of the Congress, the Humanitarian Congress Berlin. Let's hear from you on Twitter. The hashtag is HC Berlin. Thank you all and do have a good evening.